training Simple Steps to Help Save Lives, Practical Suicide Prevention Strategies for Primary Care Professionals in Training. My name is Rick Brown, and I'm the Associate Director of Communications and Membership with the Association of Clinicians for the Underserved. I'll be your host for today's webinar. For those of you who are new to ACU, I wanted to begin just with a little bit of information about us. We are a transdisciplinary membership organization uniting clinicians, advocates, and organizations in the shared mission to establish a robust and diverse workforce to help transform communities to achieve health equity for all. We do that by leading excellence in advocacy, clinical, operational, and equity excellence. We provide professional education, a host of programming, also free training and technical assistance, advocacy, and more. And you can learn more about us and our membership at clinicians.org. Just to begin, I just wanted to let you know that if you're interested in more resources on suicide prevention and primary care, we have a host of these available on our Suicide Safer Care page. There, you can find a variety of resources, including our new Quick Tips Guide for healthcare professionals in training. I'm going to put the link into the chat, and you can also scan the QR code, which I will leave up for just a moment. Okay. Before we begin, I also just wanted to go over a few quick housekeeping items. First, if you haven't yet, please complete our pre-survey. It's tremendously helpful to allowing us to assess and improve our trainings. And I am going to go ahead and put this into the chat as well. Second, we will be recording this session, and we will send you the recording and slides within a week of the webinar. We also encourage you to ask questions via the chat during the presentation as you think of them. Dr. Little and Dr. Mitton are wonderful at sort of answering on the fly, so please don't hesitate. We'll also have a dedicated Q&A at the end of the session as well. To note that also at the end of the session, please also be sure to complete our evaluation and post-survey. It's very helpful. Lastly, I am honored to introduce today's speakers. Dr. Virna Little is the Chief Clinical Officer and co-founder of CommonSpirit Health. She's also a co-founder of Zero Overdose and an ACU Advisory Council member. We're also pleased to have with us Dr. Julian Mitton. Dr. Mitton is System Director at CommonSpirit Health and Clinical Associate Professor at the Baylor College of Medicine. We're excited to have both of them with us today. And with that, I'll turn it over to Dr. Little to kick us off.
Great. Thank you so much. Really glad to be able to be here. And I'm going to turn it to Dr. Mitton just for the moment to just give a little bit more of an introduction, because we're going to be calling on him a little bit as we go forward today. So Dr. Mitton, I'm going to give you a moment.
Thank you, Dr. Little, and thank you all. I'm really looking forward to joining this session. I recognize that I need to probably get a new headshot. I think that one was taken shortly after having my second kid, so I was looking a little sleep deprived at that point. I am System Director for Population Health Policy at CommonSpirit Health, based in the San Francisco Bay Area, as well as was mentioned, Clinical Assistant Professor at Baylor College of Medicine. I'm an internist and addiction medicine physician by training. Had the opportunity to practice as a primary care doctor in a variety of clinical settings, including in a community health center, an urban community health center on the East Coast, and with the Indian Health Service in rural parts of this of our country. Before joining CommonSpirit at the enterprise national level, I completed my training at Mass General Hospital in Boston, where I completed primary care residency, chief year, as well as a health services research fellowship in that setting, and have a real policy, research, and clinical passion in addiction medicine, as well as integrated behavioral health. When I joined CommonSpirit, I had the opportunity to dive more into the operations side of integrated behavioral health, and have been really lucky and fortunate to cross paths with Dr. Little and her Concert Health team as we work and strive to increase our patients' access to compassionate evidence-based behavioral health care. The topic of today is near and dear to my heart because of some personal and lived experience, and I'm really happy to be joining and appreciative of all of your time in bringing attention to this critical topic. Thank you.
Great, thank you. So this webinar is really designed for primary care providers, learners, and their teams to really help care for patients who are at risk for suicide during the course of a normal primary care visit, if there is such a thing as a normal primary care visit. But certainly what we know is that suicide experiences or thoughts are not uncommon. When we think about the number of people who think about suicide, you know, when they looked at high school students, 66% of our high school students had thought about suicide, right? So many of the patients that we care for certainly think about suicide. And so understanding that we're going to have people care for people who are at risk for suicide. So one of the things we want to start off with is talk a little bit about language. You'll hear me say died by suicide. People commit crimes, they die by suicide. Also really looking at changing language around successful or unsuccessful attempts. I often talk about a 13-year-old who was introduced to me after trying to die by suicide that morning. You know, here's so-and-so, she had an unsuccessful attempt. So what are we really saying? You can't even die by suicide successfully, or had you been successful, you wouldn't be here with us. Also, really, I never try to pretend to know someone's intent. How many times in our life have we had to say, well, that wasn't my intent, right? And so I don't try to know someone's intent. And it's interesting to me, oftentimes in electronic health records, when I get to review charts, I'll see in big letters, patient was manipulative, patient is attention seeking. So what we really want to try to do is not use language around intent, but rather we know that somebody who talks about suicide is more likely to die by suicide. So I start there. What's really going to be helpful to our team is to document what somebody said or what somebody did. And that's going to be way more helpful for caring for that patient, using words like caring for versus working with, right? Or dealing with. And that someone is diagnosed with versus this is what they are. They're a borderline. I actually had someone say that to me today. So when we think about the number of people who are dying by suicide compared to some of the other, you know, chronic illnesses or deaths, you can see that, you know, we're losing at a certainly way more than what is reported. Probably going to be around 50,000 people this year. So really, certainly a tremendous public health issue. And this project is part of a larger, or this webinar is part of a larger project where we've actually gone around to primary care providers and their teams in about 30 states now. And what we heard is that most primary care providers of all disciplines said, hey, I think it's part of my role, but nobody actually got any training. And so really trying to bring in some training so that providers know exactly what to say and do during a primary care visit. And so why are we really focusing on primary care? We've learned a lot. And one of the things that we know is many people who die by suicide saw their primary care provider in the month of death. We also know that people who are disengaged from care, no dental, no mental health, no primary care, actually resurface in primary care the month of their death. We also know that people use the electronic portal, so the MyCharts, the patient portals, much more in the month of death. So really thinking about how we identify and care for people at risk in primary care is going to be helpful for helping us to reduce the number of suicides. And also starting to understand who's at risk. I know that when I was trained, it was very different. And we said, oh, we're going to lose people to suicide. We now know that suicides are preventable. And we know that certain populations are more at risk. So we know that many of our senior patients don't actually get the care and treatment that we need. And I know I had a provider say to me the other day, well, I care for older people. Of course they're sad, right? They're old. And we know that just because you're a senior doesn't necessarily mean that you're sad. We also know that for seniors, most of them don't get the care and treatment, and that many of the deaths by suicide are actually seniors. And so really making sure that we understand they're at risk and that we ask about suicide. I never thought I would use the words pediatric and suicide in the same sentence as much as I do today. It actually breaks my heart every time that I say it. The 10 to 14-year-olds, incredibly higher numbers for suicides. When I think about 8.9% of our high school students attempted suicide in the past year, that to me is a staggering number. And that, you know, more than 18% of them actually seriously considered suicide. That to me, when we talk about a crisis, that rings up. And one of the things we know, particularly for this age group, is that it's very lethal attempts. Number one is hanging, number two is jumping off buildings. So very, very lethal attempts. We know that the regulatory bodies, the Joint Commissions, the HRSAs, the CARFs, all of those are saying you really have to start to think about your population of patients at risk for suicide and put some processes and training in place. We also have to start to think about where we have some holes in our system. So this is a pretty famous Swiss cheese slide from some of the zero suicide work. But to bring it home a little bit, you know, there are places where patients fall through the cracks. So as an example, we had someone die by suicide, and she had called and she canceled the primary care appointment, canceled the women's health appointment. And the person who answered the phone at the front desk didn't know she was at risk for suicide. So they didn't know to do anything different. And there was no system in place that said, hey, this person has canceled multiple appointments. And so people fall through the cracks like that all the time. And I always like to say it's kind of like wrapping a warm, fuzzy blanket around your patients at risk for suicide. How can we keep them from falling in the cracks? How can we make sure that people on our billing teams and front desk teams know that someone's at risk so that they can do something different? If you haven't been to the Zero Suicide website, I encourage you to go there. It is incredibly helpful and has some CME and different webinars that you can do. So as we've been traveling around the country, we heard a couple of things. So the first we heard is that I don't have the knowledge, right? I don't know what to do when someone tells me they're thinking about suicide. And one of the things we know, and we can certainly throw some things in the chat if you have some ideas, is that one thing saves lives more than anything else. And anyone on the team can provide it. Doesn't matter your licensure, your background, how long you've been in the team. It's hope. Hope saves lives. If people have hope, they don't die by suicide. And so it's really important that we give people hope. We also oftentimes hear, I don't know what to say. And so one of the things that we want to do is we want to make sure that we think about what we might say. And so oftentimes people in our lives we've had situations where we've told somebody something maybe for the first time. And that first couple of seconds after we told them was like, oh, do I regret telling them? Am I going to keep talking? And so those first couple of seconds after someone tells you that they're thinking about suicide are really important. So what I like people to think about is to have on hand what I call storage statements. And storage statements actually came out of when I used to train behavioral health providers, and they would be doing clinical care with patients, and they would get every once in a while a little discombobulated. And so we came up with some general statements that they could use that would be applicable, and they could kind of get their footing again. And so when we think about storage statements for suicide, what are some of, you know, the things we want to convey to someone in 2 or 3 sentences that we can have, that we can tell someone who just told us they're thinking about suicide? So what do we want someone to know? We want someone to know, I heard you. Thank you for telling me you're thinking about suicide. We want someone to know that we care about them. Thank you for telling me you're thinking about suicide. We care about you here at the center. Your life is very important to me. We want them to know that we have hope for them. I have hope for you. I can see how strong you are. It took a lot for you to talk to me about suicide, right? Or your thoughts of suicide. And so I really encourage you at a staff meeting or tonight when you're brushing your teeth, think about those 2 or 3 sentences that you might say to someone who just told you you're thinking about suicide. And I've had so many providers, so many residents, so many trainees come back to me and say, you know, I didn't actually do those storage statements. And I had a provider, I've had several providers actually email me and say, you know, I didn't do the storage statements, but I was so glad I remembered yours. So really encourage you, you know, again, practice at a staff meeting, practice at rounds where you can actually come up with some storage statements, 2 or 3 sentences to respond to someone who's just told you that they're thinking about suicide. The other thing we hear a lot is, you know, with such a short amount of time, I don't have any time, right? And I've worked in primary care my whole career, and that is, man, it is fast paced, right? We are going all day, every day. And so there's a story that I like to tell, and actually my husband knows I tell it now. So is a true story. He was actually hit by lightning and had some significant hearing loss. And so we went into the primary care provider office. Wonderful medical assistant took his height and his weight, his blood pressure, and then kind of left the room. And I thought to myself, that's a little weird, but you know, I didn't say anything. And so a couple minutes later, the primary care provider came in and she said to him, she took his blood pressure again and she said, I'm really concerned about you. Your pressure is through the roof. And she asked him a couple of questions, asked him about some medications, asked him, you know, what had happened that day, and said, listen, I'm really concerned. I'm not sure, you know, you're going to be able to go home, but let me go finish up with my other patients and then I'll come back. And she did come back. We did not talk about his hearing loss that entire rest of the visit. In fact, all we did address was his blood pressure. Turns out an ambulance ride and a stent later. But the point is that in primary care, it would be a beautiful day if people came in for just one thing, or what they actually came in for was the most important. And whether his blood pressure was through the roof or whether he has said yes to suicide, we do the same things. We stop, we ask some questions, we get some information, we come up with a plan and an appropriate level of care. We do this all day. And so really getting you to start to think about what you already do and really applying that to patients at risk for suicide so that you're not panicking, you're listening, using your storage statements and responding to people that have told you they're at risk for suicide. So there's a couple of things to keep in mind. I know that when I was trained, I was taught about, you know, patients at risk for suicide, and we've learned a lot. Many patients who die by suicide don't have a mental illness at the time of death. The social determinants play a huge role. The housing, the finances, the relationships. We had a provider in upstate New York who stood up after one of the trainings and said, I had a patient, we were really worried about him. He had a lot going on medically. I saw him, my team saw him, I called him, my team saw him, called him, and he died by suicide last week. And when I think about it, he had medical problems. He wasn't able to work as much. He had financial problems as a result, which caused relationship problems. They were, you know, possibly going to lose the house. He had started to drink a little bit more than he should. And he was absolutely at risk for suicide, but we didn't really think about suicide. And so really understanding those social determinants play a role. Many patients don't have depression. Anxiety is actually a huge risk factor for suicide. And we're seeing more anxiety than depression these days. Alcohol and substance abuse. Also transitions. Oftentimes people think about transitions coming from a hospital, and people are absolutely more at risk for suicide coming from a mental health or medical hospitalization, but also all transitions out of physical rehab, substance use treatment, incarceration, foster care. Those transitions put people so much at risk that oftentimes it's really helpful to ask them about suicide. And when we ask people about suicide, we want to ask them what we want to know. So I used to work in family violence work, and I used to ask providers, how do you ask patients about family violence or intimate partner violence? And they used to often say, well, I ask patients if everything's okay at home. I said, well, that's not really what we want to know. What we want to know is anybody hitting or hurting you at home, right? Like, what do we want to know? And so we should ask patients directly about suicide. Many of my patients who are having some of the experiences you are think about suicide. I'm wondering if you're thinking about suicide. We know overwhelmingly in the research, right, that talking to someone about suicide doesn't give them an idea, right? And so asking people what we want to know, and also really combining it with some of the work that we're doing around screening for depression, where we're actually asking about suicide. I would also encourage you to start to think about your panel of patients and how many patients are at risk for suicide. Oftentimes I'll ask providers or organizations, tell me what you're doing around diabetes, and providers get so excited to tell me how many diabetics and the A1Cs, and they have this registry and they added a diabetes educator. And then I'll say, well, how many patients do you have at risk for suicide? And we don't track. And so really starting to think about a population, there's something you can do today, right? We live in a world where there's a code for everything, right? I'm in South Carolina right now. I go outside, a bat falls on my head, my water skis catch on fire, right? We have codes. There are codes for suicide risk. The R codes are there. They're in your EMR. You could put them on your problem list right away. And what that means is that then you have a structured data way to track your population. It also means that if I'm away and Dr. Mitton is covering for me and he sees suicide risk on the problem list, he's going to ask different questions. He might make different decisions. So it's really important to know that information. Oftentimes people will say, well, my patients aren't going to want suicide risk on the problem list. And I often say it's really about the conversation. Thank you for telling me that you're thinking about suicide. You know, we're really important to me. And I just want to let you know that every time that I've put suicide risk in your chart, because I want to make sure that every time I see you or I talk to you or my team sees you or my team talks to you, that we ask you if you're safe. And so no one has ever said no. And so really having the conversation. The other thing that I really encourage you to do is to think about two populations. So oftentimes we spend a lot of time thinking about identifying the person that came in, right? So somebody gets identified, they answer yes to question 9 on the PHQ, and there's, we know we have a process in place. But oftentimes we don't have a process in place when people come back for care. So I know I'm diabetic. When I go into the primary care office, they do certain things because I'm a diabetic. What do you do differently in a visit if someone is at risk for suicide in a follow-up visit, even if I'm connected to care? And so really thinking about what that looks like. We had an adolescent in a school-based health center, went in to get some forms filled out, answered yes to the suicide question, lots of commotion, right? Got referred out. Came back 3 weeks later, different provider, wasn't on the problem list, same forms to be filled out, got the forms filled out, came in and out and left. No one asked him about suicide. No one asked him if he was safe. No one asked him if he was connected to care because it wasn't in the problem list. There was no process in place. And so really thinking about what that looks like as two populations of patients. And what does excellent care for patients at risk for suicide look like in your organization? And so really giving those things some thought as you go forward. So we talked about screening for depression. All of you are familiar with the PHQ-9. I also put the PHQ-A here for the adolescents. And what I really like to do is, whether it's on the computer screen or whether I have it in paper, is I actually go through it just like people filled it out. So I can see that you're having trouble falling asleep or staying asleep, sleeping too much, and that's a problem for you nearly every day. And I see that you're feeling tired or having little energy, and that's a problem for you more than half of the days. So those are probably related, and it's going to be really important that we talk about and try to get you sleeping a little bit better. I can also see that you have thoughts that you would be better off dead or hurting yourself in some way, and that's a problem for you more than half of the days. So what I'd like to do is start there and just talk to you a little bit more about your thoughts of suicide. thank you for telling me you're thinking about suicide. Your life is very important to me, and I really appreciate, and I have hope for you. I can see, I know how much it was, how hard it was for you to answer the question, so that we could talk to you about suicide, right? So that you can go right into your storage statements. I also included the ASQ up here, just to bring it up. We're going to talk about risk and how to understand patients are at risk. The ASQ can be found on the NIMH website. It is a screening tool. I actually think it's a little bit better to work with adolescents and children. I think it's just a little bit easier. It also has a really nice script for nursing staff and parents or guardians. So certainly, oftentimes organizations will put the ASQ on the bottom of the PHQA. So wanted to put it out there. And if you hadn't heard of that ASQ, it can be a really important piece. One of the things that we want to make sure as well is that we're really sending people to an appropriate level of care. And so we know, right, that that's part of what we need to do. So when somebody comes in and they have asthma, we don't automatically send them to the emergency room. And in fact, we know that sending everyone who is at risk for suicide to the emergency room is actually dangerous, right? Because many people don't need to be there. One of the things we know is that if we send everybody to the emergency room, what happens? Then they say, well, why am I going to go there? I would just go right to the emergency room, which we don't want. Or they say, I don't want to go to the emergency room. I don't need to go to the emergency room. And so I'm just going to stay home. And then we have patients with asthma with suicide risk staying home. We don't want that either. I worked in an emergency room for like 17 years, working with patients that were sent there for suicide risk. And I can tell you nothing magical happens in the emergency room. We can ask a lot of the same questions, and that most of the people who were sent didn't actually need that level of care. So we want to figure out how we can assess risk and have a little bit of an understanding of risk, and what that looks like. And so we can know what that is in a primary care visit. And so many of you are familiar with the Columbia scale. This is what I affectionately call the primary care version. One of the reasons that I like it is because it's color coded. And it can really be helpful for saying, this is what we do with the yellow patients, this is what we do with the orange patients, and this is what we do with the red patients. Sometimes people will say, well, what if we just ask the first 2 questions? I say, you know what, just ask all 6. You're asking questions anyhow, and it's really good to be able to know. So one of the things that makes somebody red, and that's really important to understand, is intent. I can think about suicide. I can know how I would die by suicide, but do I intend to die by suicide, right? Have you had these thoughts and had some intention of acting on them, as opposed to I have the thoughts, but I wouldn't do anything about them, right? Have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? So where I have intent, those are the people who need some additional eyes perhaps and may need an alternate level of care. The intent makes the difference. I had a patient, I don't know if many of you have ever been to Poughkeepsie, New York, but there's nothing to do in Poughkeepsie, New York, except there is a walkway over the Hudson, used to be a railroad. And I had a patient and he was sent to me by the primary care provider, answered yes to question 9. And he said, I said to him, well, would you die by suicide? And he said, well, I would go to the mid-Hudson walkway, and he knew where he would jump. I don't want to land on the railroad tracks. I don't want to land on Route 9. I need to go before they put up the fence so people wouldn't jump. He knew exactly. And I said, do you intend to jump off of the mid-Hudson walkway today? And he said, absolutely not. I have to go to work. I have this new girlfriend, right? So very much about intent, right? Do I intend to carry out the plan? The other thing is protective factors. So what are some reasons you wouldn't die by suicide today? Which is literally what I ask people. And so people will say, my children, and I reinforce it, yes, your children really need their father. My family, right? Spouse or parents, yes, pets, absolutely. Your pet needs you. I've had people who have pit bulls and, put them in a shelter. Yes, absolutely. They wouldn't be adopted. Religion, job, many healthcare workers will say my patients, right? I think of it as like a seesaw. So the more risk I have and the less protective factors or reasons for living, the more at risk I am. The more protective factors I have and the less intent, then the less risk I'm at. So really it's a little bit of a seesaw. If I have no intent and lots of protective factors, then I'm safer. And so really weighing those out and oftentimes weighing them out with patients. And then really doing something called safety planning. So safety planning, we used to do something called contracting for safety, which we don't do anymore because we know it's dangerous. We do safety planning, and safety planning in and of itself is actually a clinical intervention and has been shown to save lives. So there's a couple of things that we can do for our yellow and orange patients that are actually incredibly helpful for them and keep them safe. Now we have the 988 line. This used to be the suicide line. I actually have to definitely change the slide. We have 988, the national line now. What I do is I have people pull out their phone and put 988 in their phone. And you can even say, why don't you give them a call? I'll go see another patient. And they can actually give them a call so they know what happens. The crisis lines are evidence-based. They've been shown to save lives. They've actually been shown to be more effective than mental health treatment in some cases. Most calls are resolved in that one call and don't need follow-up or intervention. So really important, you're giving people an evidence-based intervention available to them 24 hours a day. I also give them the Now Matters Now website. It's evidence-based. It's been shown to reduce suicidal thoughts and behaviors. It also has a really nice section for primary care and other learners there. And it will be really helpful for people 24 hours a day. I have them pull it up on their phone. I have them pull it up on an office computer. I used to have a tablet when I worked in the emergency room or in primary care that people could pull it up. Very, very helpful for them. I would give the Suicide is Different website if people brought family members or partners or caregivers with them to be helpful and to give them some support. So those are the things that you can do for the yellow and orange patients. You've given them multiple evidence-based interventions available to them, incredibly helpful for pretty much all of the patients in those categories. So when we think about safety planning, we're starting to hear more and more about safety planning and fire prevention. So when we were young, if I were going to poll all of you and say, what do you do if you catch on physical fire? Everybody would tell me stop, drop, and roll. Like, I don't remember when I learned it, but I know it, right? We all know it. And so really thinking about what do we do if we catch on emotional fire? We all know what to do if we catch on physical fire, even though the likelihood that we're going to catch on physical fire is low. But we don't know what to do if we catch on emotional fire. It turns out some of the same things work. If I stop, drop, and roll, I'm not dying by suicide. If I put cold water on myself, that disrupts the thoughts of suicide. If I look in someone's eyes, whether it's on my phone or somebody in person, that is helpful, not making any decisions. So really giving people some emergency plan in case they catch on emotional fire, because risk could change. I could not be at risk this morning and be at great risk this evening. So really giving people that emergency safety plan and telling them, I just want you to have it. You've had the emergency safety plan for what to do if you caught on physical fire forever, right? So here's what to do. This is actually on the Now Matters Now website, and it's really helpful. Also thinking about means restriction. It's important to know how people would die by suicide. The interesting thing about means restriction is that if somebody's thinking about dying by suicide and using pills, and I restrict their access to the pills, they don't often switch. My personal theory is I think it gives people hope. So we really want to make sure that we are talking to people about means restriction and letting them know it's temporary. This doesn't mean that you're never going to be able to drive. It doesn't mean that you won't be able to own a gun or go hunting in the fall. I do this for all of my patients who are at risk for suicide. And it's important to put the preferred means in the chart, maybe a little note in the problem list there underneath so that it's there. And really asking people, so oftentimes we think that the medication we're prescribing people is what they might use to die. When you ask them, where would you get the medication to die by suicide? Well, when my grandma died, my aunt saved all her medication and she has bags of it. Or we had somebody say the other day, well, I live next to CVS. I would just go there and buy whatever I could off the shelf, right? Think about now, what would you do with someone at risk for suicide for pharmacy? So can you get the individual pill packs? I love Amazon pill packs because they come in the little pill packs. If I have to open every pack, I'm much less likely to overdose. Can we give partial prescriptions? Do we have pill boxes, right? Are those things available to us? Also talking about guns. Is it possible that someone can take the key to the gun cabinet, right? Is it possible that someone takes the ammunition? Because oftentimes you find that, you know, if I need to take guns from someone, I don't have a license for guns, right? But I could take ammunition or I could take the key. So really talking to people about how to restrict access to lethal means is going to be incredibly helpful. It's also important to be able to talk to people about other safety planning and other activities that might actually be helpful for them. So what's something that you might be able to do when you're feeling at risk for suicide? We just need to make sure that something that they pick is available to them. So like oftentimes I'll see patient will, you know, go outside, but maybe in some places it's not safe to go outside all times of the day or all times of the year. So we really want to make sure that activities that people pick that are helpful for them can be readily available, done all times of the year and all times of the day. So really giving them, and that it's something very specific to them so that they're able to do something when they're feeling like they're a little bit at risk. One of the other things that's incredibly helpful that primary care organizations are starting to do are caring contacts, so that when someone comes in, they're evidence informed. Somebody comes in and we talk to them and they go home. Maybe they're a yellow and an orange patient, and we send them a little note, not asking them to do anything. This actually came out of Australia, where people were getting discharged from the hospitals into the outback, and they sent them a note, hey, just thinking about you, hope you're doing well. And that reduced the number of suicides. And so to send a note to someone after you've seen them the first time, hey, really glad we had a chance to meet today, looking forward to your visit next week, you know, Dr. Mitton. And that actually has been incredibly helpful for patients and really gives them hope. And here's some examples of some caring messages that people have used. And just in conclusion is, I know that when I worked in the emergency room, I used to send caring notes for people I sent home, and I had a clipboard and I would just write a little note, really glad we had a chance to meet, hope you're well, and I would sign my name and pop it in the mail. And I worked in a community where the likelihood you would run into somebody that you cared for in the emergency room was pretty high. And I was in the grocery store with my daughter, and this woman came up to me and she pulled the note out of her purse. And she said to me, thank you for sending me this note. I carry it with me. It's helpful. And so I really want you to not underestimate your ability to give people hope, to use your storage statements, to use your caring contacts, to use the conversations you have around safety planning and risk reduction, to be able to give people hope and to think about how you care for them during the course of primary care. And it is very similar. So if you think about our asthma patient again, and you know, if somebody came in and they had asthma, you might give them a treatment, you would see them, you would talk to them about rescue medication, and whether or not they had used any rescue medication. You would ask them about emotional triggers. You would ask them about triggers in the environment or the home. You might send someone out to the home and do a referral. You might give them some education on how to use a spacer or use a rescue inhaler. You might give them a referral, for a pulmonologist or something. You would do an asthma action plan. Like all of these things would happen during the course of that visit. Very much the same for patients who are at risk for suicide. For some of these other workflows that we have, we stop, we make the visit about what is the most important, which is making sure someone doesn't die by suicide, using our storage statements, talking to someone about risk and asking the questions from the Columbia scale or the ASQ, talking to them about lethal means, talking about safety and giving some resources for 988 and for Now Matters Now. Very much the same workflows. So I want to stop there, give Dr. Mitton an opportunity. I know we can also answer some questions in the chat as well. So Dr. Mitton, I'm wondering, like, as you think back about your training and whether or not you got training on how to care for people at risk for suicide, or even, one of the things we know now is we lose a physician a day to suicide. And that's just physicians, nurses, NPs, PAs. Wondering, was suicide addressed in your training at all? What, maybe just hear some thoughts from you.
Thank you, Dr. Little. Thank you for that presentation. I really appreciate many of the practical steps that you shared with all of us, and how those could be integrated into our clinical practice in the primary care setting. From a training and trainee point of view, I had the experience of both having a close colleague and co-learner of mine during my pre-med years in college who died by suicide. And then during my chief residency year, a resident of ours attempted suicide. These are stories that are not unique to me at all, right? That are tragically shared by many of us here on this call and in the healthcare profession. Burnout is real. It's very real. And I think the resources to seek care are available, but the cultural emphasis on seeking those resources is limited. So thinking about how we destigmatize this topic, normalize questions around safety, burnout, suicidality, wellness, right? I think if I had the opportunity to sort of ask some of those deeper questions of my colleagues, of my fellow trainees, I wonder if the path would have looked very different for both of the individuals that I shared stories with you all today. Above and beyond just the training process, reflecting back on what I received as a primary care doctor, as a young primary care doctor, learned the questions, how to ask them about if they have a plan, and I don't really remember much beyond that. Unfortunate. I don't really remember learning about the Columbia score, about some of the nuance and storage bank questions that you shared. And I think that was a missed opportunity because it didn't really equip me with the tools, I think, to be more impactful, but also to make me feel like I have the resources and ability to do something when I encounter a friend, colleague, or a patient who might screen positive. We hesitate to ask the question, appropriately so, when we really don't have the tools or don't know what to do when we face a positive response. And I think if there was more training around these simple interventions that I could take as a primary care provider, I would be less hesitant, less scared to ask these really important questions.
I'm wondering, as you think about practice now, one of the things that has been really shocking to me, and we've seen this in our organizations work together, is that I used to tell organizations who were doing depression screening, like 1% of the patients are going to answer yes to question 9. And I see now how that number is so much higher.
Yeah.
And that 10 to 15% of patients are actually going to answer yes to question 9. And so that is such a dramatic difference. And I'm wondering, when we think about, in your role of population health, it seems to me that it's going to be more and more critical for organizations to start to think about their patients at risk for suicide as a population. I'm just wondering what your thoughts are in terms of an individual provider and their panel, and sort of your, organizational view.
Great question. I couldn't say it any better myself. I think it's critical, and you mentioned this in your training. It's critically important to think about ways that you could proactively identify patients that could be at risk of suicide. There are a variety of ways that could be facilitated. Potentially through EHR, the development of tools to extract data through your EHR. That can be a complicated one to actualize, but I think on smaller scale, turning to members of your multidisciplinary care team and thinking about how you can assure that patients are being assessed for suicidality in the intake process, that there are ways to flag patients that in an evidence-based fashion that are at risk, and you included, Dr. Little, many of those risk factors. So, thinking about how workflows can be developed just within your own clinic with your care team members, I think is a potentially impactful way of taking that proactive step in identifying patients. I think it also affords patients the opportunity, when they're on the receiving end of a question around suicide that they themselves haven't brought up, it begins to destigmatize the topic and normalize it, so that if there is a time in the future where they really are considering something more serious, they feel like they have a trusted resource and team to turn to. And I guess my one final sort of thought on this topic is, as a primary care provider, we often face the burden of feeling like we need to fix it all alone, and really thinking about how important it is to build a team to respond to these patients, turning to colleagues and resources in your community, in your practice, even the national resources that Dr. Little shared here, finding ways to share in the responsibility and wrapping services around a patient. It's really a model of integrated behavioral health, which I think is of benefit to patients.
So there's two questions that came into the chat. One for you. What would you say to attendings who don't seem to have an interest in addressing suicide?
Yeah, it's a great question. Often people want to focus on issues that they're more comfortable and confident in teaching on, in describing. One thought that comes to mind is just pausing and saying, this is a leading cause of morbidity and mortality in our country. And to not address it would be a great failure, right? Sort of facing them with the evidence. But I also think it's really important to marry evidence with anecdote and narrative. So when I faced that situation in training, I often reflected back to my personal experiences of having a friend and colleague who died by suicide and say, you know, this is important to me because I know that a friend would be with us today if they were asked these questions, right? So finding ways to marry, to partner evidence, data. We know that this is important from a prevalence point of view. It's tragically impacting many of our communities with narrative and value on how it has impacted your own practice or your own life.
Mm-hmm. So there's another question in here that I can answer about liability. And one of the things that is really important is that we know that many patients are in primary care who are at risk for suicide. We know the data is out there that it's not safe to send everyone to the emergency room. And one of the best things that you can do is use a consistent pathway, a consistent process, and evidence-based practices. The Columbia Scale, the ASQ are the only two evidence-based risk assessments. To use them to be able to do safety planning, evidence-based intervention with evidence-based lifelines, and Now Matters Now resources, and you do it the same way every time, and you have processes in place. That's the best thing that you can do in terms of liability and saving lives. So I want to give a moment for any other questions in the chat. I really want to thank you, Dr. Mitton, today for joining me. I think it's really important to hear from someone in the field doing this work and to be able to talk about just how important it is that we start to think about patients at risk for suicide in our care and in our practices. So I really appreciate it. We are glad to be helpful or a resource for anyone. These trainings are available to primary care organizations, women's health pediatric organizations as part of a project with ACU. And so thank you so much from our friends, Rural Medical School campus in Missouri. So thank you very much. We really appreciate the shout out and really thanks for your experience. So thank you for all the folks who are putting nice comments in the chat. We really appreciate you and all of the hard work. Dr. Mitton, thank you so much again. We really appreciate you and all of your hard work, and I wish everyone a wonderful day.
Thank you, Dr. Little. Thank you all. Take care.
Thank you.